Welcome to your clinical playbook for tackling supraventricular tachycardia, all from the pharmacist's point of view. We're going to break down the key decisions, the go-to meds, and, of course, the critical counseling points you need to nail every time.
Okay, so here's our game plan. We'll start with a quick SVT refresher, then jump right into that core debate, rate versus rhythm control. After that, we'll review the meds for both strategies, lock down stroke prevention in AFib, and wrap up by looking at what's beyond the pill bottle.
All right, first things first, let's get on the same page with a quick SVT refresher. Getting these fundamentals right is so important because how we classify SVT really changes the entire management plan for our patient. So at its heart, SVT is basically any fast rhythm that starts up in the atria, above the ventricles. You can think of it as this big umbrella term. So when you see SVT on a chart, your pharmacist brain should immediately ask, okay, but what kind of SVT is it? Because trust me, they are not all created equal.
And this right here is why that question matters so much. Look, while some of these, like AVNRT or AVRT, are usually pretty benign, the two at the top are the real headliners, atrial fibrillation and atrial flutter. Why? Because they both come with a huge risk of stroke. That thromboembolic risk is the big scary thing that drives so much of what we do next.
Which brings us to the first massive decision point when you have a patient with AFib or flutter. Do we just control how fast the heart is beating? That's rate control. Or do we try to shock it back into a normal rhythm? That's rhythm control. This one question shapes the entire game plan. For the longest time, everyone just assumed that getting back to a normal rhythm had to be better. But then the landmark AFirm trail came along and really flipped the script. It showed that for a lot of patients, we're talking older folks without a ton of symptoms, just slowing the heart down was every bit as good at preventing strokes and death. A real game changer. So the bottom line is, it's all about tailoring the strategy to the person in front of you. Rhythm control, where we aim for that normal sinus rhythm, that's usually for younger patients, people who are really feeling the symptoms of their AFib, or if we're worried the fast rate itself is damaging the heart. But for so many others, especially older patients who feel fine, rate control, just keeping that heart rate below 100, is a fantastic and often much safer approach.
Okay, so keeping that strategy in mind, let's see how this plays out with our medication choices. We'll start with the drugs for a rhythm control strategy, and this is where your expertise in counseling and monitoring becomes absolutely essential.
So, when you see a new prescription for a Class IC agent, think flecainide or propafenone, your very first thought should be to check the patient's profile. These drugs must be given with an AV nodal blocker, like a beta blocker. It's a critical safety step. And of course, be ready to counsel on things like potential blurred vision with flecainide or that weird metallic taste they might get from propafenone.
And here it is, the single most important safety warning for this entire class of drugs. This is a hard stop, a non-negotiable. If your patient has any history of a heart attack, heart failure, or any structural heart disease at all, these drugs are a no-go. The risk is just too high. This is a red flag you can never, ever afford to miss.
Now, with the Class 3 agents, your safety radar shifts a bit. With sotalol, it's all about the QTC interval. You've got to be watching for that risk of torsades de pointes, especially if their kidneys aren't working well. For dronedarone, the two big red flags are heart failure and using it with strong CYP3A4 inhibitors. And hey, don't forget to mention the common stuff like diarrhea, because that can definitely impact whether they keep taking it. And then there's amiodarone. Incredibly effective, yeah, but this drug demands our full attention. This checklist is your best friend. As a pharmacist, you're perfectly positioned to make sure this stuff is happening. Are they getting their liver and thyroid tests every 6 months? Do they know about the annual chest x-ray? And your counseling is huge here. Tell them to report any new cough, remind them to wear sunscreen, and always, always check for those interactions with warfarin and digoxin. You often have to cut those doses in half.
Okay, so what if the plan is rate control instead? For a lot of our AFib patients, this is going to be the path. So let's look at the drugs you'll be dispensing day in and day out. These are the real workhorses of SVT management.
Your go-to tools here are the beta blockers and the non-dihydropyridine calcium channel blockers. When you're dispensing something like metoprolol, you'll want to make sure your patient doesn't have serious asthma, and always, always warn patients with diabetes that it can hide the signs of low blood sugar. For the CCBs, particularly verapamil, you've got to mention constipation. And for both classes, you need to be careful if the patient's heart is already a bit weak.
And just a quick but really important note on an old classic, digoxin, it's not a first-choice drug for rate control anymore. It's been moved to the backbench, really only for times when the beta blockers or CCBs just aren't cutting it, or for that specific patient who also has heart failure.
Okay, let's stop for a second, because this is unbelievably important. It doesn't matter if the strategy is rate or rhythm control. If your patient has AFib, preventing a stroke is the #1 priority, period. It is completely non-negotiable. And you can do a quick risk assessment right there at the pharmacy counter with the CHADS 2 score. It's a super simple point system. You just go down the list. If your patient scores a 2 or higher, they are high risk, and the guidelines are crystal clear. They need to be on an anticoagulant. It's a quick, powerful tool to explain why that medication is so vital.
So when we talk about anticoagulants, the guidelines today strongly, and I mean strongly, prefer the DOACs, the direct oral anticoagulants, over warfarin. And you can see why, right? No more routine INRs, way fewer interactions, fixed dosing. It's just so much easier on the patient. That's not to say warfarin is gone. It's still an option, especially for folks who've been on it forever and are super stable. All right, let's wrap up by quickly touching on the non-drug options. It's really helpful to know about these because your patients will come in and ask you about procedures their cardiologist just mentioned. You want to be prepared. You'll hear a lot about catheter ablation. It can be incredibly effective, sometimes even a cure for certain SVTs, with success rates way up in the 90s. For AFib, it's a huge option when meds aren't working. The other one you might see is LAA occlusion. This is a pretty niche procedure, really just for that small group of patients who have a high stroke risk, but also a crazy high bleeding risk, so they can't safely take any blood thinners. So let's bring it all home. I want you to think about the very next patient with AFib that walks up to your counter. After everything we've talked about, what is the one practical counseling point you've picked up today that you are going to use to make their therapy safer and more effective? Because that, right there, is where we make the biggest difference.